Okay, well, I've got kind of a lot to talk about today, so we're going to get started. We're going to let people file in if they're still coming. Uh, Thanks for joining us. The Statewide Lab Advisory Meeting. It's Monday, November 13th. I think I've got the agenda on the screen there. So one more time, if you could please put your name and facility in the chat so we can keep track of who's here. We will just go ahead and get started. Starting at the top with the laboratory topics. In the last communication drill, we kind of sent out an open-ended question asking the labs if they had any questions for us or were looking for answers. So we kind of took those. We're going to kind of fold those into the statewide meetings just to make sure everyone's questions are being answered. One of the questions was about the COVID-19 emergency use authorization for some of the COVID testing that your labs are doing. And I think to talk more on that, we've got Pete, who can probably explain how all that works better than I can. Pete?
So you think so, huh, Ben?
So
It's complicated, believe me. So yeah, there's a lot of questions about EUAs and FDAs and what tests are approved since we don't have this public health emergency declaration in place anymore. I think take a step back here a little bit and just talk about categories of approved tests. The FDA has a process for approvals, and one of them would be an assay that is FDA approved. Now, FDA approved means it has to go through clinical trials. So this is the short or the long process for a company to get a test approved. Most of the tests that we use in the clinical lab probably fit into the category of FDA cleared. FDA cleared is a process which is a fast track approval for medium risk devices where there's a substantial equivalent device that's already been approved by the FDA, so it doesn't have to go through clinical trials. If you've ever heard of the concept of 510K approval or cleared, that's what that fits right there. The FDA EUA declaration is even a faster track addressing emergencies. And that's what I'm going to talk about here in a moment. But I also want to mention that there is the laboratory developed test, the LDTs, which it really doesn't fall under FDA regulations at this moment. And there's a lot of discussion about FDA wanting to regulate those. So what is an emergency use authorization? It's a declaration by the FDA that allows for unapproved medical products to be used in an emergency and used in emergency to diagnose, treat, or prevent illness. Now, the FDA is authorized by the Secretary of Health and Human Services following a declaration that exists, there's circumstances to justify these authorized tests. Here's what we need to understand is that an EUA declaration is distinct and not dependent on a public health emergency declaration and can only be terminated by the Secretary of Health and Human Services. So the public health emergency, which was declared in January 31st, 2020, did expire in May 11th of 2023. Do we have a comment? Okay, moving on. So the HHS secretary has indicated that circumstances still exist to maintain the EUAs because COVID-19 continues to be present as a public health emergency. And also there is significant potential for COVID to affect the health of the population. So that's why the EUA is still in place. As far as the EUAs go, they can be terminated under two different declarations by the secretary. One is they can do a broad termination and say, we're going to terminate all EUAs associated with COVID, which they have not done. Or the Food and Drug Administration may individually revoke a EUA, which has happened. If there were circumstances to justify that it's appropriate to protect the public health. Now, you may recognize if you go onto the FDA website, you'll notice that there's probably 400 to 500 different COVID EUAs on that website. But the FDA has slowly taken them off and removing their approvals. And many of the serological tests were thought to not be that good, so they've actually removed the EUA approval. So you can do them individually. Now, just a little bit about the public health lab and the EUAs, and it'll kind of talk about what you guys are seeing in your labs as well. As far as the Nebraska Public Health Lab goes, we have the CDC multiplexed COVID-19 real-time PCR assay, which is an EUA. Multiplex means we can test for both COVID, influenza A, and influenza B. We also have in the public health lab the Cepheid quadruplex COVID influenza A, B, RSV test, which is an EUA as well. And I suspect that some of your clinical labs out there actually are using this assay for COVID testing. Some of the labs out there also might have other automated systems such as, BioFire, Hologics, the Cobas, TacPath. I mean, there's a whole bunch of them that are out there. Those are all considered EUAs. Also in the public health lab, we have an Ebola Marburg RT-PCR, which is a BioFire panel that we use, which is only designated for certain public health labs that have been approved by the Department of Defense to have this in their labs. We also have a MERS test, which is an RT-PCR EUA, and we have an avian influenza AH7 CDC RT-PCR test. So these are all the EUAs that we use in the clinical, in the Nebraska Public Health Lab. We do not use the Cepheid Mpox assay, which I think some of you folks might be using in your laboratories. That is considered an EUA as well. We use in our lab the FDA cleared assay for variola and non-variola testing. So we have an FDA cleared test for that. So I hope that kind of explains where we're at with the EUAs. They are still in effect, and they are not dependent on the public health emergency declaration. And I'm sure we will all hear about it if the FDA decides to terminate the COVID testing, but I don't see that happening anytime soon. So I'd be open to questions that anybody has out there. Brian, does that kind of, Ben, does that kind of explain what people were interested in, do you think?
I think so. And you said there was a list of the COVID EUAs.
Yeah, you can go on the FDA website. If you just put in your search engine FDA EUAs, you can pull up any EUA you want, whether it's COVID, whether it's influenza, whether it's Ebola, and you can see what's out there. Many of the EUAs that were approved were actually, interestingly, were approved for individuals, such as a reference lab, like ARUP has its own EUA for testing, Quest Diagnostics, LabCorp does. But you can pull those up and you actually can click on their test and find out more about their EUA declaration and when it occurred and how they got that EUA. So it's all kind of interesting to me sometimes to see what testing was done to actually get approval, because they didn't run a lot of tests sometimes to actually show that the test worked. So somewhat it's interesting. Also, the concept of pooling clinical specimens, which we kind of started here in our lab a few years ago. There's a number of EUAs now that companies have that are actually approved for pooling of samples as well. So it's kind of interesting to see that. So that's kind of the breakdown, the ideas of EUAs as it pertains to COVID and other diagnostic tests.
Yeah, thanks. So,
okay.
Yeah.
I'd be happy to, if anybody ever had any questions on this or similar topics, send me an email and be happy to answer that as well.
Great. Okay, thanks, Pete.
Do
Yes.
we have any idea how long the FDA is going to take to approve some of these tests?
No, the answer is no. You know, if you look at the FDA website, for instance, I'm going to refer back to Ebola. You know, Ebola started back in when, 2014. There are still EUAs for Ebola on their website. So I suspect it's going to be a long time. I don't see a mass, declaration to say we're going to stop these EUAs. I mean, the companies are not going to allow it. How many of the companies are actually looking to get 510K clearance for their products? I don't have a good answer for that either. I don't know of any FDA cleared COVID tests. Now, there may be some out there, but I just don't know any off the top of my head. So it would be up to the companies, I guess, to decide when they want to do that, if in fact they have to. And one other interesting thing is the vaccines for COVID are also EUAs as well, and some of the treatments. So it isn't just diagnostic tests.
Pete, is that something that labs will just have to monitor for their own test system, or is there go out?
I'm sure that if anything comes up, the companies, the manufacturers are certainly going to let people know what's going on. As far as I'm concerned, I think that it's not going to happen anytime soon. And, we are going to hear about it if it ever did.
Okay.
Okay.
Okay. There's no more questions. We'll move on. All right. Thanks, Pete.
You're welcome.
So a couple of labs were asking about the carbapenemase testing. The results for like the modified carbapenem inactivation method and the PCR. In September, we sent out a news alert saying that you should be getting the results for those. Those should be flowing back to the facilities. And if your lab is not receiving the results, please get a hold of me. Bring along like a specific case, patient, whatnot, so we can look that up and try to troubleshoot the issue. Because your lab should be receiving the results for both the MSIM and the PCR if it follows the algorithm and is appropriate. So you can send me an email or call me, and we can try to get that sorted. So then the influenza submissions, flu season has begun. And so we want to send out a reminder for the labs that do to submit your flu isolates. I think is I hate to call you out, but Eric, are you on the call today? I think DHHS
Yep, I'm here.
sent out. Did you sent out a notification about influenza submissions not too long ago? Is that correct?
Yeah, we would have, when we sent out kits to the Sentinel sites, there would have been some information on just recommendations on when to submit your isolates to the public health if you're a Sentinel site, because we sent out like 10 collection kits and we recommend to submit 2 or 3 specimens during like the beginning part of this season, and then so on and so forth through the middle and just to kind of capture the full season as it progresses over the next few months. But if any labs have questions or further questions about that, I'm happy to continue the discussion.
Okay, thanks. Yeah, I think word was that it was looking a little light on submissions, I suppose, for this time of year, which could be totally coincidental. But we just want to put out the reminder that it's flu season.
Yeah.
And
Yep, and not surprised that it's light for this time of year because we haven't seen a whole lot of influenza to this point here in Nebraska. But when we get to the flu RSV update, I can touch a little bit more on the activity.
okay, perfect.
Thanks.
Thank you. And then we should have Andy Dillahay with us here today. We've been trying to get Andy on to talk for a while now, and it's finally worked out. He's going to tell us about some of the hepatitis testing he and his team are working on. Andy, are you here with us?
I am. Can everybody hear me okay?
Yes, we can. I can.
All right. Well, thank you for the invitation to be here with all of you. I'm excited to tell you a little bit about what is going on with our viral hepatitis program here at the state. So we're currently in the third year of a 5-year grant cycle, which is the first time they have done any kind of surveillance funding. So it's an integrated surveillance and prevention grant that we are currently funded under. Part of our requirement is to do a lab assessment, a lab needs assessment. So what we're planning to do is we have an assessment developed. We're going to be sending it out to the top 5 highest volume labs here in the state and get some feedback about what kind of testing is happening in regards to hepatitis. So from the basic questions of, are you even doing hepatitis testing, to looking at all the different types of hepatitis testing that's going on in the labs. We have a technical advisory committee that is sort of spearheading our efforts and creating an elimination plan that is part of our grant requirement, but also by doing this lab survey kind of gives us a better picture of what's currently happening in Nebraska, where we have room to improve and celebrate some of the successes we're already seeing. So currently we are working with 5 different sites that do a rapid point of care test. We have some in Douglas County, Lincoln, Lancaster County, and then some other parts of the state. Norfolk as a spot where we're doing it. We have a place at the Santee Health and Wellness Center that's doing it now. And then in terms of results of those tests, those sites are then able to send draw off to the Nebraska Public Health Lab for confirmatory testing. So viral hepatitis, there is not a lot of money in that compared to some of the other infectious diseases that we get funded from the CDC by. It's a fraction, I would say maybe less than 25% we receive versus our HIV prevention and surveillance programming. But there is a definite push, especially from the federal government, to have a hepatitis elimination plan that kind of covers the country, but then individualized for each specific state. So I would also like to pose an invitation to all of you. We do, in addition to our technical advisory committee, we do have a hepatitis elimination coalition. They meet alongside with our HIV planning group. We see, of course, a lot of overlap in the populations that we serve. We're trying to integrate our programs more to take more of a syndemic approach, looking at not just conditions, but also some of those social determinants of health as well. So it all kind of ties together, especially as we're looking at this lab survey. But that will be going out very soon. And in addition to that lab survey, we will be doing an assessment of the top 5 highest volume health systems in the state. I should say this lab survey will be like a 10 to 15 minute red cap survey, pretty straightforward, really simple. And then for those health system assessments, we'll be doing phone interviews between staff here at DHHS and then with our technical advisory committee. Yeah, I guess that's kind of just a quick snapshot of what's happening here. So I am happy to answer any questions that anybody has. I'll also put my email address in the chat. So if anybody wants to contact me outside of this meeting to discuss any of this further, I am happy to do so as well.
Say, Andy, this is Pete at the Public Health Lab.
Hi, Pete.
Do you, in your lab needs assessment survey, do you have any information in there about sending samples to reference labs?
We do have questions about that in there, and then ask what reference labs are used. Mm-hmm.
Okay. I'm assuming that that's being done a lot, so I just wanted to make sure that was captured.
Yes, thank you, Pete.
Mm-hmm.
No other questions? Okay, well, thank you, Andy. I'm glad we finally got you on to talk.
Indeed. Thank you so much for the opportunity. And yes, I'll put my email in the chat and please reach out if you have any questions or input. Thank you.
Okay, thank you. So that brings us to the DHHS section updates, which we'll just start at the top of the list here. move on down. So we're gonna start with Ishrat for the HAIAR, hospital-acquired infections. Is Ishrat on? I thought I saw she was on.
Yeah, I'm on. I'm on.
Hi, Ishrat.
Can you hear me? Okay.
Yes.
So we don't have that much update, but we actually, a couple of weeks ago, we had one known Candida auris patient who was actually, who tested positive in Illinois, but he had been in Nebraska. The patient had been in Nebraska for a long time. So we are aware of this patient. So this patient actually sought care at a nursing home in Nebraska. And we notified them within 24 hours, but the facility thought that they had a little bit of infection breach, so they were kind of concerned about it. So they decided to do a point prevalence screening of 28 people that were at risk, they thought. So we sent out the specimens. I mean, the facility sent out the specimens to Minnesota Regional Lab of 28 people, and then they all tested negative. So no concern there. Usually in these cases like that, when somebody we know was colonized with Candida auris, but they don't test positive anymore nowadays. Instead of putting them in contact precautions, what they call it is enhanced contact precautions, enhanced barrier precaution. It's a little bit less than regular precaution, but the facility was aware of it. But everything got sorted out. But so all good news. That's the update we wanted to say. I don't know if anybody else from my team has any updates.
Yeah, just for enhanced barrier precaution, specifically is for the nursing home. So that's something that acute care hospitals probably will not be implementing on that patient. That will be still contact precaution. Enhanced barrier precaution allows people to get out of their room and get involved in group activities and things like that. And but it still requires gowns and glove use when you are performing very close direct contact care to the patient. So it's kind of a middle ground for people to still be able to move around in the lab, so in the nursing homes where they are living. So that's basically the enhanced barrier precaution, and used for any multi-drug resistant organisms that are targeted organisms in the state. So CPCREs, even you can consider that for ESBL organisms also in the nursing home population. So thank you.
Thank you. Yeah, negative screening. That's good. Thanks, Ishrat. We'll move on to SARS-CoV-19. If Samir is on. Perhaps not. Oops. That's me. Sorry about that. Miss Samir is not with us today. Is that what I'm seeing? Well then, Derek, you are back up for RSV and flu.
Alrighty, sounds good. So I'll go ahead and give an update on flu, and I'll start with like a little snapshot nationally. So nationally, influenza is starting to increase over the past couple weeks. That increase is primarily being observed in the south and southeast part of the country. So that can generally be an indicator on when we can expect here in Nebraska to start seeing increases. So I would expect in the upcoming weeks or month that influenza activity will begin to ramp up in Nebraska. But as things stand right now, activity is pretty minimal. The little flu activity we are seeing here in Nebraska is primarily influenza A, and then specifically H1N1. We actually haven't had any H3N2s subtyped out yet, or any influenza Bs as well for that matter. And nationally, that follows suit with what's being subtyped of. I think roughly 78% of all influenza positives are influenza A. And then among those influenza A's, roughly 91% have been H1N1s as well. So nothing too surprising there. Then with RSV, we are seeing increases here in Nebraska the last couple weeks. Our positivity has been increasing about by 1 or 2% over the past 2 or 3 weeks. I think we were sitting around 6.5%, if my memory serves correctly. So that's not unusual to be seeing RSV increase. And actually, this is a little more as we would expect in a pre-pandemic season in terms of RSV seasonality. So nothing unusual, but just be aware that we're seeing an increase in RSV activity. So with that, I'm happy to take any questions on flu or RSV.
Okay, thanks, Derek.
Thank you.
Brianna or Claire, is there any news about enteric outbreaks?
Hi all, this is Claire. Brianna is out today. We don't have any local outbreaks that we're currently looking at, but we do have several cases that are being added to CDC multi-state clusters or outbreaks, basically on a weekly basis right now. We've had a couple added to STEC outbreaks. We have 2 or 3 different salmonella clusters that they're looking at right now. We did have a listeria case added to a cluster that was interesting because their strain was nearly identical to a cluster that they investigated back in 2020 out of Minnesota that was linked to buffet restaurants. So we're trying to do some digging there. We haven't seen any other similar strains kind of across the US. So that one was just kind of interesting. And then we do have a couple extensively drug-resistant Shigella cases that have also been linked to a multi-state cluster. So if you guys are seeing any Shigella cases come through, it may be worthwhile to look at drug resistance there, because that was really the only way that we had them notified that they were connected to this cluster, because it's Shigella sonnei. So otherwise, these cases aren't necessarily whole genome sequenced if they aren't targeted as extensively drug resistant. So otherwise, we have no outbreak updates for the state of Nebraska as of today. So thank you.
Thank you. Arbovirus. Jeff? Well, we'll talk about TB testing. Any news with TB testing?
This is Kristen. We have been working closely with NPHL regarding a large contact investigation in the state. Other than that, I don't really have any updates.
Okay, thank you. And then finally, lead testing. Were there any questions for Kristen? I'm sorry. There might be some questions about that. No? Okay, thanks, Kristen. Do we have Sandra or Darion for lead testing?
Yeah, sorry. No major update from lead today.
Okay, great. Just some news and notes from NPHL, some training. The challenge set went out, was completed. The review has been recorded. That's been posted to the website. If you didn't get a chance to join live. I was just recently given the LPX results, and I'm putting that into a review. Invitations will go out soon. If you'd like to sit in through a review of the LPX, the CAP survey. And StatPack, we're working with a couple of labs on StatPack right now, kind of finalizing some things and testing. If you are a lab in Omaha that was working with Karen on StatPack, expect to hear from me in the next couple of days. And if you've indicated in the past that you have a lab that's interested in getting StatPack set up, expect to hear from me in a couple of weeks. We're going to kind of start moving the ball on that. And that is really all I have. I don't know if there's any new staff updates or if anyone has anything off the cuff that they'd like to bring up. Questions or anything? Okay, well, that's really all I have. One last time, if you haven't yet, if you could just put your name and facility into the chat, so we know who was here and who was representing which facility. Other than that, laboratories are welcome to jump off. The DHHS people hang out. So we can have our chat. Thanks everyone for attending.
Thanks, Ben.